gentlemen, apologies for, and I'm also conscious apologies. So you're starting the recording, Vanessa?
Yeah.
Super, thank you very much. So welcome, ladies and gentlemen. Apologies for that slightly dysfunctional start to the board meeting. Technology is a wonderful thing until it goes wrong, and I think this is the first time we've had a significant problem. But welcome to everyone. We have a pretty full agenda today, so I will get us all going. So we have apologies for absence from Catherine Free, our medical director, but grateful to Martin Zandler for deputising for Catherine, and we have apologies from Jenny Norcott, who is on holiday this week. Any new declarations of interest? Please raise a digital hand. Okay, thank you. So the minutes of the last meeting held on the 4th of May, was everyone happy with the accuracy of those minutes? If you weren't, could you please raise a digital hand? Okay, I can see no digital hands, so thank you for that. I'll duly sign those in due course. So we'll then go to page 22 of the pack for the matters arising. The first was the freedom to speak up guardian to ensure the nursing and midwifery category in figure 3 of the report be split into separate categories. Sue will do that for the next meeting in August. Thank you. Then we had the Stephen to arrange for a video on the virtual ward to be brought back to the future warden for the AGM. That's scheduled, Stephen, for next month, so looking forward to that. Thank you. Then myself and Hack to discuss the Trust financial position in more detail. Thank you, Hack, for your very clear email. Then we had future mortality reports to reflect learning from patient deaths, including those where patients had learning disabilities. Catherine's carrying that forward, and we'll see that at the start of August. And then myself and Glenn to be briefed on the financial position should there be any significant change. Hack, that wasn't necessary, was it?
That's right, no it wasn't.
Thank you. And then the half 1 and half 2 financial plan to be brought back to the board in June. Looking forward to seeing that in the private agenda. Thank you, Hack. And then things carried forward. The first was Dowgy to review and bring back a report on any additional IP&C board assurance framework indicators. We come on to that on the agenda. Thank you, Dowgit. Then the acute provider financial benchmark report to be brought back to the board. That's also on the agenda. Thank you, Hack. Then the restoration recovery report on priorities and risks. That's also on the agenda. And also that report to be brought back today, which it is. And a new improvement report to be presented to the board next month, or in August rather, so looking forward to that. Thank you, Hack. Are there any matters arising that I've missed? Okay, well, hopefully Glenn is able to talk to us through 4G. So Glenn, do you want to pull out the key things from your report, please?
It doesn't feel quite the same talking to you in this way, but I'll go through it nonetheless. So I won't go through everything. It's quite a big report this month, actually. So firstly, I talk about the information and communications technology business case, which came to the board last year. It's an update on the situation we've reached, which is dispute with the main unions involved. In my paper, I refer to having gone through stage 1. We will now go through stage 2, which involves you, Chairman. But I just wanted to make it really, really clear that the intention of this arrangement is to create a really first-class NHS IT function, not to transfer it out of the NHS in any shape or form, but by creating the model in this way using the arm's length company, we will be able to recruit and retain even more staff to develop even more IT into the future. So hopefully we will work through that with the unions and reach a satisfactory conclusion. The other one I then wanted to talk about was digital innovation. We talked about this at our 3 boards meeting. I've attached a newsletter, which is the first newsletter, which sets out what the Digital Innovation Hub is for. And board members hopefully saw on Friday, I sent out a further slide pack, which gave some live examples of some of the digital innovation that is going on across the group, which is really quite exciting, actually. And we discussed in workshop this morning a strong appetite from board members to see more of that as it develops. There's then something I refer to as clearing the financial fog, and in the background an alarm is now going off, so I'll keep going, which is about how we move from the H1, the first half of this financial year, into H2, and hopefully create a slightly more familiar NHS financial regime. A particular concern here that I flagged is the potential loss of incentives for organisations to manage their finances. So heavily lobbying and working with the national team to try and reach a conclusion on that. And then I wanted to talk about left shift. So we discussed this a little bit last time. So this is on page 5 of my report, where this will help us to develop a place-based financial strategy. The idea of left shift is there's always a level of activity that could be delivered in a lower care setting, which is a better setting for those individual patients. And often the best example is stepping patients out of hospital into supported care in the community or into home. We're going to do a point prevalence study again, which we've done before, across the whole Coventry and Warwickshire system, which will identify for us the potential to left shift if we were to right size our capacity in a way to cope with that. We're also going to start to look at that in line with our place-based financial strategy. And there's 2 other categories. So left shift is today. We could be seeing these patients in another setting. There's a further category, which is tomorrow. With technology, we could be delivering that care in a different way in a lower care setting. And then finally, through prevention, there's a further left shift, which would prevent those hospital admissions in the first place. And those 3 numbers added together will identify quite a significant level of financial opportunity for us to invest in better care for our communities. So that will start to shape our financial strategy. And then finally, I refer to the latest IXL award winners, so Stephen Church and Scarlett Williams. And then also there's a further update from some of our great teams, so fractured neck of femur nurse specialist, and an update from the urgent care director on some of the great work they're doing. And the one thing I would pull out from the great work they're doing, we were commended at the recent review of the system for the very low number of turnaround delays for ambulances. And that was brought into sharp focus last week with some scary national statistics of patients suffering as a result of that. We've been commended for our very rapid turnaround times, and I'm pleased to see that continues. So I'm happy to take questions on any of those, Chairman.
Thank you, Glenn, and thank you for persevering with the technology. Questions or perspectives to Glenn, please raise a digital hand. I think the work, as you're describing, Glenn, on left shifting and point prevalence is incredibly important for the future. There is an enormous prize for us to be more efficient and effective as a system, serving out citizens more in a home setting, which is better for their health outcomes and is also, frankly, often better for their emotional well-being as well. So important piece of analysis to come to the board in due course. Are colleagues happy to move on? So I think it's over to you, Stephen and Hack, on the Estates Quarter 4 update, please.
Yeah, so if I'll deal with mainly with the trust estates update, and I just want to pull out a couple of pieces from the report and a couple of areas of focus. And the headline one that I think will be coming to board in July, and then I think if Hack wants to pick up any of the system and the strategy piece. So the bit I just really want to kind of pull through as a theme is still the amount of work that we're able to do, even despite the kind of COVID and the increased pressure on the site, and really signal some of the work that we are doing. And I think I think what's really important is this is work, and what I would point to is the Adam Bede refurbishment that we're planning to do. Because these are things that we've been waiting to tackle as a trust for a long time, and we're now getting ourselves in a position where we're actually tackling some of this infrastructure and getting it on a really good footing. I think sometimes it's easy to be attracted to the new ward and the 2 new theatre programme that are going on, but there's some really important estates work going behind. So I feel like, and I think staff are feeling like we are tackling some of those long-standing issues, and they can see that as an improvement as we go forward. And the one that I would point board members to, and when you're able to come on site, it'd be really good if you could see it, is the work we've done around what's the Chevrolet wing, particularly around IPC, where we're putting doors onto bays. And actually, the feedback again from the staff is it's really uplifted the environment, and it makes it look quite modern, and is quite stark really to how it might have been seen in the past. So I think they're really important bits of work. And the bits that I just want to flag for board, kind of give an early sight on, is we're bringing the sustainability strategy next month to board, and that'll be working its way through TMB and the others. So we're heavily linked into the system piece. And kind of underpinning that is a piece of work that I'm starting off with Kirsty, is around the car parking. So we'll have a car parking plan, and where we're looking at in depth. So that's things like the provision for cycling, how close people are to the site, how we can maximise the green agenda, but also maximise the site that we've got and the car parking, because we know that from staff and patients that's an issue that frequently crops up. So plan is in the next one I'll update on that and give board an update. Hack, I don't know if there's anything you want to go through.
Hack?
Just a couple of things I was going to flag. One of those carries on from what Stephen just said around the green travel plan and how that links in with potential development of additional car parking spaces going forwards as well. And the second bit was the development of potential development of a community diagnostics hub on this site, subject to us getting the funding. So we have put a bid forward for a £7 million development on close to where the estates building is at the moment, where we've got some of the older wards. As I said, that's subject to that bid being successful, but that would provide some more diagnostic facilities on this site for the local community.
Thank you, Hack. Just before I pass it on to colleagues, Stephen, can you just remind us where we are with the League, our friends at the League of Friends, on the coffee shop, please?
Yeah, so as soon as the restrictions lift and we can open the site back up, we're all good to go for getting it refurbished, and there's a timeline for that.
Super. Well, it's been an incredibly busy and fruitful year, as you said in the introduction, Stephen, given the context of the pandemic. Questions or perspectives to Stephen or Hack? Glynis?
Thank you, Chair. I just wanted to touch on the backlog, Stephen, because maternity obviously has got a significantly bigger backlog of maintenance work than any other area. I just wondered what level of risk this poses and what plans you've got in place to address them.
So the risk has been well known, and we've got quite versed mitigation plans really about if something was to happen, particularly around the theatres, where we would go and what we would do. So we've been carrying that. I think that's the theme that I was really pulling through, is some of this stuff has been there for quite a while, and actually it's the kind of thing that always gets moved or kicked back, and actually we're determined this year with maternity and the Adam Bede refurbishment that we're going to tackle that. It's in the capital plan, so that's the work around that.
Thank you, Stephen. And Rebecca?
Thanks, Russell. Stephen, could I just seek a little bit of clarity about a couple of previous capital programmes that we've identified? They're much smaller. One was connected to HSDU and a project around some updating there, but also as well, I think there was some issue in regards to our catering services accommodation that was picked up in an accreditation visit last year, and whether both of those schemes are within this programme, albeit smaller monies.
I'll have to check on the HSDU one, so I'll give you feedback outside if you like, Rebecca, just on that one. And the catering one, so the inspection, I know we received our 5-star rating for it, so I think that's been addressed, but again, I'll confirm out of here.
Thank you, Stephen. Any other questions to Stephen? Glynis, is that a legacy hand? Okay, no worries. Okay, well, just before we move on, I do think it's congratulations to the whole estates team. I know the business cases involve a total team effort, but when you think what we've achieved during the course of the last year, during the pandemic, I think it is quite an extraordinary level of achievement. So well done. Good to have you back on Wi-Fi, Glenn. Thank you, Sarah, to join us. We'll therefore move on to the Warwickshire North Place update. David, in Jenny's absence.
Yes, thanks, Russell. So I'm going to talk to this report on Jenny's behalf. Her and her team have authored this, and this report goes to a range of partners across the Warwickshire North health economy. So it isn't just coming here, it's also gone to various other partner organisations. And essentially what it does is set out some of the progress that we've made. As you know, over the last 12 to 18 months, we've been focusing on developing relationships, planning, creating a strategy, engaging with the Health and Wellbeing Partnership Board across Warwickshire North. We're now focused, and indeed this is one of my objectives, now focused on moving into a much more delivery orientated programme. And we've established a place delivery group to take that work forward. And you can see in the report references to the work of that group, developing its project management, its programme management plan, and starting to put some measures in place to demonstrate progress against the various pieces of work that have been signed off as part of the plan. There's quite a bit of information in the report about benefits realisation. It's fair to say there's quite a bit more work to do around that to develop the actual measures that sit behind that, but it's good to see people talking about those outputs and outcomes, which ultimately are what we will say benefit the population of Warwickshire North as we move this work forward. And the plan is to have a dashboard that not only looks at the process measures that are in place, but very clearly details some of those outputs. Appendix 1 of the document, I think, is particularly useful in terms of providing some examples of the hard pieces of work that have already been delivered and the next steps that are to come. And I think other than that, I'll take the paper as read, and if anybody's got any questions, I'll happily deal with them.
Thank you, David. Questions and perspectives, Julie?
Thanks very much, David, and I think it's really good to see this paper and so important to be working at Place. I guess things are changing so quickly and at pace at Place, but I think it's how we respond to, how this programme responds to things like the Diagnostic Hub or the Accelerator programme. How do we make sure that they are working together to get the maximum benefits?
Yeah, so in both of those examples, there's been really good engagement at Place. So the people who've been senior responsible officers within the hospital have been working with partners. Relationships are really good. So if you take the Community Diagnostic Hub as an example, Catherine has been leading on that. She's involved our GP colleagues and colleagues from our community services. And indeed, our community service sits at our Trust Management Board as a sort of virtual member of the Trust Management Board, even though they're managed by a different organisation. So there's really good relationships from that point of view. All of those projects are being discussed at the Place Executive meeting. The Place Exec meets on a monthly basis. I chair that meeting, and I'm pretty confident that we've got really good engagement as a result of all of that. It's very positive. In fact, we've had some interest from Amanda Pritchard's team in the work that we're doing in both North and South Warwickshire around Place and that ability to engage and deliver in a partnership way. So starting, I think, to shine in this regard. So very positive.
That's great. And Amanda Pritchard, for those who perhaps don't know, is Chief Operating Officer of the NHS. Rebecca?
Thanks, Russell. David, just having a look at the various work streams summary in the appendix, clearly a lot of progress being made there, but I am minded to identify the mental health work stream, and that doesn't seem to be as reporting in the same way as the others. And I wondered if you could give further explanation on that. Thanks.
Yes, thanks, Rebecca. So that's a good question, and something that we have considered at our place executive meeting on a number of occasions. And in fact, there was a workshop that ran probably just a little over 4 weeks ago that Jenny and colleagues from the Mental Health Trust coordinated. And what we're waiting for is the output of that workshop to feed into the plan, but very clearly about addressing issues at both place level and at system level. And we know there are some challenges from a mental health perspective. It's very much a focus for the Partnership Executive Group, which is the Integrated Care Systems leadership team. And Glenn might want to say a little bit more about that. But a very clear focus on a small number of things that we can do at place. So, for example, employing mental health practitioners to work out of GP surgeries and to cross into the more acute side of the pathway, and some clear thinking about that. And then some very higher level system orientated conversations about the way that mental health services are deployed across the piece. So it's fair to say there's more to do on that, and hopefully by the time we produce the next iteration of this report, we'll be in a better place to be clearer about specifics.
Thank you, David. Thank you, Rebecca. Glenn?
Yeah, just to pick up that point, I was going to make another point about Julie's observation, but yeah, we put mental health services on the system risk register. We've seen obviously a worrying post-COVID impact, particularly on younger people accessing acute services with mental health issues. So we really do need to keep a focus on that system level. It is a national problem, but it does, and we discussed, didn't we, this morning, that it's maybe an opportunity for us to have a discussion with our Coventry and Warwickshire Partnership Trust colleagues on this at place. I was going to make the observation linked to Julie's point earlier about the community diagnostic hub, and I referred to it in the clearing the financial fog piece. There's a lot that's happening at very short notice at the moment, requests for bids for capital and revenue. And so that's why it's really important for us to have a really clear place plan that looks much more further forward than that, so that when an opportunity to bid for something comes forward, we've actually got we can demonstrate that it fits into a place vision, whether that's the clinical strategy or whether that's an estate strategy that we have at place. So no excuse for us not planning on a longer term basis, even though the NHS is a little bit short term at the moment.
No, thank you, Glenn. And I think the other aspect in terms of the importance of the focus on place is for us to help our citizens live longer, happier, healthier lives. And we should remember that people in Bedworth have a male life expectancy almost 10 years younger than people in Stratford-upon-Avon. So people are dying 10 years earlier than they would in Stratford-upon-Avon if they're male. For us to address that and help our communities address that, we must work more at place. The current solutions haven't worked. We must work more at place. So there's a real need to keep this going at pace to the betterment of the citizens that we look after. Colleagues, happy to move on? So I think we're then on to restoration, recovery and reset. Stephen? When I say Stephen, I mean Hack.
This is me, thank you. Thank you. The report describes the review process we have recently undertaken of the Restore, Recover and Reset programme and that transition to the improvement programme. So we've reviewed 81 projects across 7 work streams and identified those that need to be carried forward, and they're detailed in the report, and those then that become business as usual. Going forward, we've also looked at lessons learned and some of the themes coming through around making sure we continue to build on the approach that we have taken, which is around improvement being clinically led and being led by those that are closest to delivering the services to patients, having clear roles and responsibilities, particularly in terms of the role of the coordination cell, and making it clear where we do involve the coordination cell that's clear that they are adding value to those projects. Also light touch governance, so focusing on delivering the improvements rather than lots and lots of paperwork, but making sure we get the balance right between the governance elements and the delivery elements, but very much a focus on delivery and delivering at pace. The other element in terms of lessons learned was around measurement of improvement. The focus has been very much on delivery as we've been in the COVID phase, and because of how projects have been set up quite rapidly, the baselining hasn't always happened, and the measurement has been variable, I think, between projects. So it's a greater focus on measuring that improvement, being really clear at the outset what the baseline is, what the target is that we're trying to achieve, and how we're going to measure that improvement, then be able to demonstrate very clearly that we've delivered the improvement that we intended to. So in terms of moving forwards, we'll build on those projects that are being carried forward in terms of what are the, and to do that, we'll look at the strategic priorities. We've got at place also the ones that we have at organisational level, including those that are coming out of the directorate level service development plans. So going forwards, there's a key focus in terms of driving productivity, but also using technology to deliver some of the kinds of improvements that you've already heard about within the meetings so far. And there's a couple of improvement stories included in the report that demonstrate some of the use of technology to deliver patient care in a more appropriate way and avoid patients having to come to hospital unnecessarily. I'll leave it that. And in terms of going forwards, the governance process is about reporting through TMB to the Improvement Board, and the Improvement Board will receive updates every other month, and we'll also report to from the Improvement Board to Trust Board every other month. The first update of the improvement programme to Board will be in August.
Thank you, Hack. And I love the phrase distributed model for improvement. I think that's very important. Any questions or perspectives to Hack? Julie?
Thanks very much, Hack, and I'd like to confirm for the board that there was an internal audit report undertaken on the work of the coordination cell, which actually gave it substantial assurance, which is really good to hear. Just a couple of questions, Hack. One was around, again, it's this theme of how do we make sure that the work associated with things like the accelerator programme and also PACE, the clinical productivity programme, are actually included in this work, but then also how things get in and out of the sort of a gated process to actually agree what goes in to the work of the cell.
Yeah, I think the key element of a couple of the key programs that we've got are the Theatres Improvement Programme and the Outpatients Improvement Programme, and they, I think, are key to in terms of delivering the kind of things that you're talking about there. And they're not new programs; they're relatively well established, and they are progressing in terms of demonstrating some of those improvements already. And we'll see that coming through. I think in terms of the activity levels we'll achieve going forward, and part of that is around making sure we make appropriate use of the new additional activity that's got that we put into place in terms of additional beds and the new theatres that are coming on stream in the next couple of months. So what was your second question?
It was how you prioritise, I guess, is how you actually get into the work of the programme. So some sort of gated process or some such thing.
Yeah, so one of the things we're looking, I think a lot of the priorities have been going to be driven in terms of whatever the priorities are at place, and in terms of the trust priorities. I mean, one of the concerns we have is around trying to do too much all at once. So it's being really clear what are the objectives we're trying to deliver. So the SROs are key. So every work stream will continue to have an SRO going forward. So they're absolutely key to helping with the prioritisation process. And one of the things we're looking at is potentially an SROs group that we haven't had previously, which is around looking at either crossover between various work streams and projects, but also around if we are looking at if we are trying to do too much at once, that SRO group can review the workload and prioritise in that kind of way in terms of what projects we are taking forward or what pace. So it will be a joint review across the SROs.
Okay, just a bit conscious of time. Stephen, did you want to come up on that point?
Yeah, it was just I wouldn't cover the ground that Hack did. I think there's, just to bring to life for board, I think there's a real marked difference in the organisation So I think one is we're focused on 1 or 2 outcomes, not hundreds of outcomes, and trying to do everything at once. That we've been really clear with that. The best example I can give is probably, to make it real for board, is around hospital occupancy and long length of stay. So we've just come in off another bank holiday where we're running at 80% occupancy. ED's been working really well over this, so that it's a whole hospital thing that's come together, but they're just focused on 2 outcomes. They're just looking at what's the occupancy, what's the long length of stay. And I think that I can't stress enough how it's been owned by the directorates. That's the massive shift for me, is they're the ones running this and doing it. It's not, we haven't got external people in, and it's not me doing it as an SRO, it's them running it. So I think that's just an example that kind of brings it to life, how different it is at the minute.
Very helpful, Stephen. Just keeping the pace going because we're running late now. Glynis?
Thank you. It's just a request, please, Hack, and actually quite appropriate given Stephen's comments, is that I know we're involving patients in shaping these, which is great, engagement is good, but what I would really appreciate, as well as the benefits such as reduced length of stay or hospital admissions, is how it feels for the users, for the patients. I just want to ensure that this is actually giving them a positive experience of care. So at some point, can we bring back users' experience of these projects as well as part of it, please?
Thank you, Glynis. And then finally, Rebecca.
Thanks, Russell. Very positive to hear about the move towards a distributed model for improvement, which means it's everybody's business. Though, could I just ask what steps we are taking to assess that we don't have any hiccups in infrastructure or governance, so that decisions can be made as in an agile way as possible, closest to the patient?
I think some of this is around recognising the governance process we've already got and the delegated authority that directorates already have, and not interfering with that and allowing people to get on with the jobs that they have to do. And I think it's kind of not seeing improvement as separate to being to the day jobs. So part of that is also being built into the service development plan. So we agree the priorities with the directorates and the service development plans, and then we monitor that performance through our normal governance processes, rather than creating additional processes or additional decision gateways. So it's agreeing up front what they're going to do and then letting them get on with it, and then managing the reviewing, holding to account and reviewing the outcomes, rather than managing every single decision they're trying to make.
Sounds very appropriate. I'm sure you lots of nodding heads in support there, Hack. Thank you. Okay, we'll move on then to the quality section of our report, and the report on safe nursing and midwifery staffing. Daljet.
Thank you very much, Chair. So this month's report continues to demonstrate the ongoing governance that's in place to ensure that where there is concerns identified around staffing, we're putting mitigations in place. This is demonstrated through April 2021 data, which is within the report, that shows we had 8 DATEX incidents raised regarding nursing and midwifery staffing levels, but they were all deemed as no harm, and the assurances there were actually no red flags raised as a result, which is positive. Also pleased to report that in April we saw significant improvements in our staff sickness associated with COVID. The amount of nursing staff shielding was also down a further 50% in comparison to March, which again very positive. The board will note that there is a slight increase in vacancies this month, and this is associated with the birth rate plus in the business case that came to the board last month, and we're in process of recruiting to those posts. So that's where the increase is explained. Positive progress also in terms of recruitment to our registered nurses and healthcare support workers. Just to give you a bit of context in that, as the report highlights, we've recruited 41 whole-time equivalent registered nurses and registered midwives and 35 whole-time equivalent healthcare support workers, and it really demonstrates the reduction we're making in the vacancies. Need to be mindful that many of our registered nurses are newly qualified nurses. They do not qualify till September, so won't come into post then. I think George Eliot has a very strong reputation of recruiting newly qualified nurses, and I think it's important to note that supporting and nurturing these staff as they transition into their roles is really important. So we have a very robust preceptorship programme for them, which is has very good feedback from our newly qualified nurses.
Areas with highest vacancies are also within the report, but pleasing to note that ED has, after being a hotspot for vacancies for a long period of time, is no longer featured. Again, that's a very positive progress regarding that. This month, you'll see that we've also included some data around midwifery safe staffing levels to demonstrate that that is reviewed on a daily basis. And you can see the report demonstrates on a small number of occasions the delivery suite coordinator was not able to be supernumerary. But again, we've covered this in previous board reports, and the business case and the recruitment to those posts should really mitigate that issue going forward. What is really good is that through this, we've been able to demonstrate that 100% of women received one-to-one care in labour from a midwife in April 2021, which is very good experience. The additional roles to be recruited to result of the midwifery business case are out to recruitment, and as I said, the coordinator issues should be resolved. Happy to take any questions.
Thank you, Darjit. Very comprehensive, very clear, and some good areas of progress. Any questions or perspectives to Darjit? Thank you for your hard work, Darjit. So we'll move then on to the CQC progress and preparedness update. Yeah. What would you like to pull out here?
Thank you very much. Now things to pull out is that we've had positive progress on closure of some of our amber actions, which you will note. We've now got 5 outstanding, one of which is a must do. Mitigations actions in place are described in the report to close those as well. The other thing, just to inform the board, which is not noted in the report, but following the relocation of the sexual health services from the Pine Clinic in Rugby to the Sexual Health Centre in Hill Morton, the CQC has registered that service and there's been no issues with that. I'm happy to take any questions.
Thank you, Darjit. Any questions on the CQC progress and preparedness update? Rebecca?
Just a quick one, if I may, Russell. Darjit, of the outstanding actions by area, I think only is it action 8 for ED has got a trajectory date for completion, and I wondered whether the others would also have a trajectory date as well.
Yeah, each one of them has a trajectory date on their tracker. I'll make sure that they're included in future reports.
Thank you.
Darjit. Colleagues, happy to move on? Okay, great. So we then move on to the management of the COVID-19 outbreak overview to receive and note. Darjit?
So I'll do the updated analysis of the BAF.
Apologies, I got too excited there.
No problems, that's fine. I can finish my reports quicker. This report provides a gap analysis, as I stated previously when I brought the COVID BAF. The February version had just been published. I went through each one of the new additional key lines of inquiry within that version of the report, and I'm able to provide assurance to the board that we were compliant on all of those. I also felt it might be helpful to give you feedback on the 9 areas where we deemed we were partially compliant in the last board report. And I'm pleased to say that we've now progressed to full compliance against a further 4, leaving only 5 areas which are partially compliant. 2 of those will be closed shortly. Actions are in progress and I expect those to be closed. The 3 remaining ones are in relation to the conversation we had both at board and at Quality Assurance Committee, that these are about keeping records centrally, whereas the trust approach is to devolve that decision making and empower the directorates rather than in certain central checks and control. So it's unlikely we will close these as per the BAF. However, again, to emphasise that the BAF is guidance only, and it's an organisation's role to review those and consider how to apply those standards locally, providing there are risk assessments and mitigations in place, which are described in the report. Happy to take any questions.
And you're entirely comfortable with that approach, Darjit?
Yes, and I can provide some assurance that in recently where we needed to provide some evidence to the Health and Safety Committee on one of our staff cases, and we were able to provide the evidence that we'd undertaken all the risk assessments for that individual.
Super, thank you, Darjit. Glynis?
I just would like to reiterate what Darjit said, Chair. We had a very detailed discussion about this at Quality Committee, and we're very assured about the mitigations in place.
Okay, that's great. Thank you. Any other questions or perspectives from colleagues? Okay, the much anticipated management of the COVID-19 update, Dowd.
Chair. Okay, so this report is an overview of the outbreak in the second wave. I'll pull out the key points in a moment, but just to highlight to board that we did discuss this in great detail at the Quality Assurance Committee, and assurance was provided on actions taken, mitigations put in place, and lessons we've learned. So the Trust's last outbreak officially closed in April 2021, and this report really provides the assurance on the management of the outbreak, the actions that we took, and the lessons that were learned from the second wave outbreak. So in August 2020, the number of COVID-19 cases started to increase again within the community, as we could see across the whole of England, really. And George Eliot responded to that, and we noticed an increase in cases around about September 2020 up to February 2021. By the beginning of October 2020, we continued to see a higher level of cases within the Trust, which raised the potential of cross-infection, or also known as nosocomial spread, again, like a number of other organisations, and not just NHS organisations, but other types of organisations who experience an outbreak. During this second wave, I think what was different, it was identified we could have asymptomatic carriers of COVID-19, and at that time figures quoted as high as 1 in 3 cases of people with COVID could be asymptomatic. As a result of this, we took a number of actions, which included increasing our universal precautions for the management of COVID-19 in all clinical and our non-clinical areas, closing affected wards, reducing patient movement, access to rapid testing, and we also undertook a review of our patients who, within the outbreak period, were considered to have a nosocomial infection and had died. So I'll come on to that in a moment. And we set up a trust-wide surveillance programme of testing all our staff. We were actually able to demonstrate that only small numbers of our staff, in comparison to the figure that was quoted, were asymptomatic carriers. By March 2021, there was no active outbreaks at George Eliot, and NHS declared the outbreak closed on the 20th of April. To provide assurance to the board, we can always follow the national guidance, which over this period changed a number of times, including new initiatives being introduced, such as all patients being required to wear masks, and also our vaccination programme was introduced at that time as well. And we continue to, as we always, follow the national guidance. Alongside the internal actions, NHSEI took an unannounced visit to the Trust on the afternoon of the 23rd of December. And to point out, the reason for their visit was because of the number of outbreaks we had in comparison to the size of our organisation, rather than any specific concerns that they had. Their feedback was provided to us in February 2021, and we are able to demonstrate that we have completed all the actions that they had highlighted to, some of already which we were taking. So that action plan has now gone to our Infection Control Committee and has been signed off as closed. It is with great sadness that both nationally and locally that there were patients who died associated with outbreaks, and our thoughts go to all the families and the loved ones who have had such devastating news at this time. It's clear that it's equally had an impact on our staff as well. The number of patients who died with COVID during the outbreak period accounted for around 6.1% of all our deaths at George Eliot during this time. Each of these deaths were reviewed in line with our serious incident framework, and an RCA was undertaken. Full duty of candour for each of the cases were also undertaken. To date, we've had 4 complaints related to the deaths of patients affected by nosocomial transmission, and those are actually still in the complaints process and being reviewed. The report provides further assurance of the care that was provided to patients through the structured judgment review of these cases, which identified that 83% of these cases were found to provide either excellent or good care. And a number of good examples are provided in there around discharge documentation, around early review by specialist teams, management, timely escalation and holistic patient care. Areas of improvement included things around discharge documentation and communication. So to provide assurance to the board, we continue to meet as an infection control team and the wider organisation on a weekly basis, and we continue to support the restoration and recovery as well to ensure that we continue to comply with our IPC guidance. I think infection prevention and control will continue to be a focal point for some time to come, and it is our desire to always follow the national guidance. Given some of the national measures and the easing of the some aspects of infection control nationally, we have really reinforced strict adherence to face, hands and space messages within the organisation to ensure that we continue to keep the organisation safe. Assurance of this is provided through regular audits done by the infection control team and the matrons, which are reported into our weekly infection control meeting and our infection control committee. Happy to take any questions.
That's a very comprehensive introduction. I'd just like to say a few words before I pass over to Glenn. Obviously, we've discussed on numerous occasions as a board how best to steer our way through what has been the nightmare storm of the pandemic. And we are very conscious of the loss of loved ones and the premature death of loved ones and the inability to say goodbye properly to loved ones that many of our citizens have had to go through. Equally, we are very conscious of the enormous personal sacrifices made by frontline teams, but also the moral and resolute courage of my executive directors on this board. You have had to cope with a series of very difficult challenges and decisions that you've had to make. So I just want to put on record again my thanks to you. Other perspectives, Glenn?
So yeah, it's a really clear report. Thank you, Daljit. I mean, just to reiterate a couple of points in there. So firstly, we still have no idea of how or when COVID is transferred to an individual. What we use in this data is a proxy date timings for it. So the highly likely and the probable cases are those that are beyond 8 days of their stay with us that we actually test them positive for COVID. And that's what formed the basis of us identifying the numbers that Daljit's just gone through. And just to make it clear to anyone who's watching this who may be concerned about a relative who's been treated by us, that duty of candour means that we have proactively contacted all of the next of kins of those involved and set out the circumstances and given them the opportunity to ask us more questions. So we proactively contacted everyone within those numbers, as sad as each individual case is. That's what we've done, and that's what we would continue to do if there was a further outbreak, Chairman.
No, absolutely. Thank you, Glenn. And just keeping things moving because we're running late now. Glenys?
I just want to thank Daljit for this report. We've received it at Quality Committee already, and I think it's a really excellent example of what a strong safety culture is being embedded within the hospital. It shows that there's, a review of all these cases, reflection, and most importantly, learning that has consistently changed practice throughout COVID. So I think we should take a high degree of assurance around it.
Absolutely. Thank you, Glenys. Okay, we'll move on. So then on to how we're doing at the moment, the integrated performance report. David, do you want to pull out the key things here, please?
Yes, thanks, Chair. So I'll just draw some headlines out in the order that the reports are presented in the pack. So the first section is on mortality. We spent a considerable amount of time at our board workshop a month ago understanding where we were with mortality. And the headline is that our HSMR continues to be outside of the expected range, although it is consistently improving. And if you correct it for the impact of COVID, it comes back within the expected range. So that's good news. More work to do on that. And Catherine will no doubt keep us heavily focused on that as we move forward over the next few months and into the summer. In terms of clinical quality measures, you can see that further improvements in the number of falls against the April-March numbers. Falls with severe or moderate harm are all reviewed on a case-by-case basis, and we have one RCA which is due to go to our June serious incident group as a result of that process. In terms of infection prevention and control, good to see an increase in cleaning scores March against April, and we have 2 cases of C. diff to report in April, which is not good news. There are RCAs in progress against each of those cases, and Daljit will no doubt update us in due course as to the outcome of those reviews. With respect to the deteriorating patient, we undertook an audit of a sample of cases of deteriorating patients. We looked at 21 cases through April and found all of those patients had received an appropriate response, so that's positive and good news. There's a governance process in place with regard to pressure area care. We had 108 reported incidents of skin damage, and there's a process in place which looks into each of those cases and again provides assurance about approach to management of skin care in the QAC. Moving quickly on to operational performance, we've already heard that A&E performance continues to be strong with 91.8% against the 4-hour standard in April versus a Midlands average of just underneath 85%. So strong performance from the organisation. That's set against a backdrop of much higher attendances with a very busy day, more than 300 attendances a couple of Mondays ago. And in some cases, we're reporting up to 150% of pre-COVID levels of attendances to A&E. Flow is good, as we've heard, and our ability to recover is good because of the focus that the ops team have put into occupancy and long length of stay, and that's a really positive story. And Glenn's already referred to the fact that although we had one 60-minute ambulance handover delay, our performance is extremely strong, and that delay was due to a spike in the number of ambulances arriving all in one go, so clearly understood. With regard to RTT and planned care, our performance against the 18-week standards still not where we would like it to be, but obviously everybody understands the impact that COVID's had on increasing the backlog there. The system, as we've heard, was successful in getting the National Accelerator programme, and we're busy putting plans in place to deliver against that. And that will eat into our long waiters and to the size of the waiting list. We don't think it'll have a massive effect on our top headline RTT performance, but we are busy modelling that, and we'll understand that in more detail as we get to a place where we're delivering against the trajectory that we'll agree for the Accelerator programme. Diagnostics, 99.2% against the 99% target was the best performance in the country, so something to be celebrated and proud of there. With regard to cancer, 2-week performance has improved in April, and we expect that to further improve through May. I know cancer is an area that the board is very focused upon, and so it's good to be able to report that improvement. 62-day performance still continues to be an area of challenge for us. It's worse in April than it was in March. There's a significant number of shared breaches in there with UHCW, and we've been picking that up internally to make sure that our referral processes are as agile as they could be in terms of the timing of our referrals into specialist tertiary pathways, and we'll continue to focus on that over the coming weeks and months. We have 2 patients reported here who are waiting greater than 104 days for their treatment, and that's a daily management task to make sure that that number doesn't grow. We've got a stroke conversation about this again at QAC. We've seen an increase in presentations and demand for stroke care, and we're also struggling with some of the things that are happening across the stroke pathway at system level. We had a conversation about how we might address that, and Stephen and the team are very focused on this to make sure that we try and get back into some kind of shape with this in short order. And we also talked about the mitigations that are in place to make sure that where stroke patients are not nursed in a stroke ward, there is a clear package of care that can be deployed to them wherever they are being cared for to make sure that they don't come to any harm or suffer any ill effect as a result of that. And then finally, under the HR category, so health and wellbeing, inclusion, bullying and harassment are all a key focus for the board. We've had a number of conversations over recent months, and indeed this morning we were talking about behaviours in our board workshop, really important stuff. And in our FPE meetings, we've been focusing with the directorates on making sure they've got appropriate responses in place to the staff survey outputs that we've discussed at board. So some really good work happening across the organisation to get to grips with that. Vacancies are low overall, and we know that the pressure points are particularly in band 5 nursing, but excellent work in progress to recruit, with a large number of those vacancies now got people in the pipeline and due to start in due course. And of course, important to be clear that we've added significantly to our establishments over the last 12 months, so the number of vacancies is reflected in that, in the sense that we have put more posts into the system and obviously are now recruiting into them. Sickness has improved month on month from the beginning of the year, and again, doing well from a statutory and mandatory training point of view, at trust level exceeding the target. But again, we know that there are some areas that require focus, particularly the medical workforce and our estates and ancillary teams, and the management teams responsible for those areas are all over that. So I'll stop there. If anyone's got any questions, happy to take that.
Very comprehensive update as ever, David. Thank you. And some real signs of progress. And an appreciation of the challenges we still face. Any questions or perspectives to David? Okay, we'll move on then to the money. Hack, we still live in funny times, but how's the money looking?
Yep, so we do indeed. So we've got a block allocation effectively for the first half of the financial year, and we submitted a break-even plan as previously reported to the board for the first half of the year. But since then we have had feedback from NHS requiring the STP to make a further improvement of £3.3 million. We need to work through exactly how that will land and impact each organisation. But in the meantime, based on the plan we have submitted, we are on track after the end of the first month, slightly better than planned, with a surplus of £400,000. That's largely driven by the activity levels and also reduced temporary staffing spend, and the reduced temporary staffing spend are directly linked to the reduced sickness levels. The area that we're focusing on for the first half of the year is driving down our expenditure run rate, and we've got a £1.9 million CPIP target for the first half of the year. We went through this with the directorates at the Finance and Performance Executive meetings last week, and they all confirmed their confidence in delivering that level of CPIP for the first half of the year. We also spoke to the directorates about what else can we do, because we're really conscious that we need to get a run rate down further going into the second half of the year. So there were some good ideas there in terms of areas that they can focus on around further decreases in COVID-related expenditure, increased productivity, further reductions in temporary staffing spend, and also reviewing the improvement projects we've got and making sure that those convert into money out as well. So that's going to be a key focus area really in terms of driving down that expenditure run rate, and that's what we're working on with the directorates over the next couple of months. Just one final point in terms of the balance sheet. We've made our final loan payment on the Salix loans, so that means we are now debt free. I'll leave it there and take any questions.
Good place to leave it there, being debt free. Questions and perspectives to Hack? Okie dokie. I mean, in the next section that we're talking about, Hack, in terms of acute provider financial benchmarking, is really the meat behind how our financial trajectory develops from here. So we'll move on to that. So Hack, still with you?
Okay, thank you. So this report has been written to address an action from the board meeting from back in March. And it was about comparing our performance relatively to STP partners, but also kind of looking at, has there been a significant deterioration as a result of COVID? We've used the latest data available through Model Hospital and Model System, which effectively allows us to compare data across organisations. So the benchmarks you see in the charts are against Midlands acute providers, but we have flagged STP partners, so Swift and UHCW, and you'll see from the charts that in most cases we benchmark pretty well. We're broadly in line with the median in most cases, but it does show room for improvement. The areas that are flagged for improvement are around staffing costs, around some elective